I'm Lisa Muser, I'm the CARES coordinator, and I just wanted to welcome you all before passing the baton to Steve Malone. Steve is the CARES board president.
Thank you, Lisa, and thank you everybody for being here and being willing to participate in this panelist group tonight on perinatal substance use and services here in Monroe County. Just wanted to let everybody know that we have Dr. Camilla Arenado. I hope I am not butchering that too bad. I think I got that correct. Psychiatrist for IU Behavioral Health. Terry Caldwell, she's at LCSW with Mom's Meal Together and Family Vitality, or Vitality, yes, okay. And then Sarah Farmer with the Associate Clinical Director at Catholic Charities. And then Chris Sherwood, Nurse Family Partnership here in Monroe County as well. Thank you everybody for taking time out of your busy schedules to participate in this panel tonight for everyone. And as Lisa said, thank you, Katz, for willing to sit and record or have this on cue for us, and we can have this safe so others can watch this. I'm actually kind of excited about listening to some of what you all have to say, because I honestly have no idea what there is here in Monroe County regarding these types of services for Bloomington and Monroe County residents and moms to be. So without that, I don't know who wants to go first. I'll probably just start with Dr. Arenado, since she's first on my list as far as presenting. I'd like to give each of you some time to do so, present any PowerPoints that you have. And I think Lisa has some questions at the end that we may be able to ask in case others don't have any as we finish up here with everybody. So Dr. Arenado, I'll let you take off with it and go from there.
Okay, I don't have any PowerPoints to share, but as Steve said, I'm Dr. Camila Arenado, and I am an addiction psychiatrist, and I focus on the perinatal period. So I focus on taking care of people that are pregnant or postpartum. And I'm going to talk about two different places where I see patients and where people who are pregnant in Monroe and the surrounding counties can seek help. The first place that I'll talk about is the Addictions Treatment Recovery Center. So that is through IU Health and IU Behavioral Health. And that's located still on the site of the old hospital at the Hunter School building. It's on the second floor. And I'm work there as the medical director. I don't see very many patients there other than pregnant and postpartum people, but it is a service available to other residents of Monroe County and the surrounding counties who are not pregnant. But we do offer services for this population. And essentially the ATRC is it's one of 4 addictions treatment recovery centers within the IU Health system. They're each in different regions, and our one here in Bloomington is the one for the South Central region. We basically provide IOP programming, and IOP means intensive outpatient programming, and IOPs can function for many different psychiatric illnesses. The one that we have is a dual diagnosis program, meaning it serves people who have addictions or addictions and other general psychiatric illnesses like depression, anxiety, PTSD, bipolar disorder. So individuals that are struggling with both addictions and other mental illnesses can participate in this program. Generally, people have to be there about either 3 to 5 times per week. And we have 3 different sort of times that people can come, like a early morning one, a slightly later in the morning, and then we also have an evening program. And this consists mostly of groups, although it does also involve individual therapy. It also includes medication management and assessment. So we'll meet with you and make sure we have the diagnosis correct, and then we'll provide both psychiatric medications, and also we provide MOUD, so medications for opioid use disorder. We provide medications to help to curb cravings for other addictions as well, including alcohol use disorder or sedative hypnotic use disorder, and stimulants. So we treat all the different kinds of addictions. We specifically have the medications for opioids use disorder, Suboxone, which is something that many people in our community are seeking. So we do provide that. Patients or people who come to our program, they can be self-referred. So if someone realizes they're having a problem and they want to come, they can self-refer. And we have a nurse who takes the information and discusses the program with you, and then sets people up for an initial intake with one of our therapists, where additional information is gathered, and then a treatment plan is made to see if the person is interested in the level of services that we're providing, and and enrolls in the program. And it is an in-person program. People generally are an IOP anywhere between 3 to 6 weeks, but it can vary based on what the person needs and what they're able to, time they're able to take away from other responsibilities. We have recovery coaches that work on that program. So these are individuals with lived experience who are currently in recovery themselves and provide various forms of support. If the person who comes to our program is too ill for outpatient services, we help them to connect with residential services. We also accept people coming out of residential services into our program. Once you finish the program, you can continue to receive therapy and medication management at our program, if that's appropriate for you. And we also have what are called aftercare groups and some other specialty groups that people can do once they finish the initial IOP portion. We don't take people in without IOP into this program because of our limited staffing for it. So you have to begin by doing the IOP portion, and then you continue on for less services, but you can't initiate with less service. I hope that makes sense, and I can answer more questions about that later into this particular program. So this program, we welcome perinatal people. We generally have, especially pregnant people in it. It's a little bit harder for postpartum people to participate, even though we do have an evening group. So sometimes that's more possible for people, but it is in person. So that can be a little bit challenging. I hope to develop a virtual version of this for really focusing on what we call a perinatal track. We've been trying to develop that for a while now. With everything that's happened with the pandemic, it's delayed that process a little bit, but it's still on our to-do list to try to be able to help more people. And when Terry Cardwell talks about their program, theirs is not, the program that she's going to talk about is not meet as often, but it is kind of the idea that we would like to have in our program just more often, and in the IOP version. So once it talks about her program, you can understand a little bit of what we would wish to have. So that's one of the places where I work and where we offer services for people in the perinatal period who have addictions. The other place that I work is, so this is at the old hospital site, right? So think back old days. For those of us who've been around for a while, that's still over there. Now move yourself over to the east side of town to the new hospital. People are probably aware that that is where deliveries are now done in Bloomington. They're in the new hospital. They're on the first floor. They've also made a very, in my opinion, smart decision to move the OB providers for their outpatient services to the same location, meaning that when you're getting your prenatal care before you've delivered, you're also going to the hospital, but you're not going into the admission part. There's an outpatient part. It's also on the first floor. So we, in that first floor area, which is the outpatient part that serves pregnant and postpartum people, we have an embedded behavioral health sort of program inside of the OB office. And that has me in it doing medication management, and also my colleague, Ashley Beeler, who does our therapy. So this program is for pregnant and postpartum people up to 1 year after the birth. And what we provide in this program is evaluations and diagnostic evaluations with Ashley and with myself. We take on people who already have medication providers, but whose medication providers are not comfortable prescribing during their pregnancy. And we also initiate people on treatment who are not in treatment already. And we take care of people with general psychiatric conditions and also people with addictions. And in that program, we partner very closely with Terry, who's going to be talking in a minute, for the group program and for a lot of the therapy services for our pregnant patients who are experiencing substance use disorder. So these individuals can be referred to our services by themselves. They can request from their obstetricians or midwife to refer the patient to us, or the nurse practitioner or nurse midwife or a physician who's taking care of them can identify a problem and refer them to us. And then we will see them and we'll manage them up until 1 year after their pregnancy. After they deliver, we start trying to find referrals for them for when they're done working with us, which anyone who works in Bloomington or the surrounding counties knows what a challenge that is. So that's a big thing that we work on during the postpartum period. We also, through this program, something that we're trying to expand, we've already started doing it, is to do some inpatient consultation. So sometimes people who are using substances aren't really able to get a lot of prenatal care for a number of reasons. There's stigma around using substances while you're pregnant. There's a fear of DCS. There's a fear of just judgment from the physicians and the medical community. So a lot of folks are identified at the time that they're giving birth. So we are working on having more services at that time to be able to come and meet people when they are there, to both maybe not while they're delivering, because that's a pretty stressful time, but after the baby's born, and attempting to engage them in services at that time. So that's something that we've kind of already started doing, but we're trying to expand that. In terms of the other service that we provide for people with substance use disorder is to initiate medication-assisted treatment or medications for opioid use disorder, buprenorphine. You can just do that as an outpatient. A lot of clinics in Bloomington you've probably heard of, including ours at the ATRC. We just do it as an outpatient. But when you're pregnant, it can be a little bit more complicated, especially when you're getting closer to delivery time. And as I said, a lot of times people aren't identified as having substance use disorder during their pregnancy because they're avoiding care a little bit. So we have partnered with the OB team, and Dr. Lillette Wood in particular and myself created a protocol here in Bloomington. They had it at Methodist, but we brought it down to Bloomington so we can do it as well, where we can initiate people on medication-assisted treatment in our hospital when they need that level of care. This is sometimes needed, like, for example, we have someone that we're planning to work with who is on methadone, but is having trouble being able to go to the methadone clinic every day. It's very tricky to change from methadone to Suboxone. It's not normally recommended to do that during pregnancy. However, sometimes with all the barriers that we have with people living in outside counties, it's necessary. So that's an example of a situation where you'd want to bring someone into the hospital. And so we have added that possibility. And we've worked a lot with the nursing staff at our hospital to really help with stigma reduction. Patients have commented that they really feel more comfortable there than they have in the past. Our hospital is also using what's called Eat, Sleep, Console, which is a way to monitor the babies once they're born, because some babies can have withdrawal, although not all do. So we're really trying to integrate inpatient and outpatient OB services for individuals with substance use disorder and general psychiatric conditions, actually, to provide a better continuum of care through the programming that we're doing. So it's very early stages, but everything being in the same building has really, really helped with that. And so we see a lot of possibilities for continuing to improve what we're doing.
Thank you. I know I said we'd take questions at the end, but before I forget, I got a quick question for you, Doctor, because I'm afraid I'll forget at the end.
Sure.
Do you know the percentage of you would consider duly diagnosed as far as psychiatric issues and substance use disorder issues. Do you have any idea as to what percentages there are that are duly diagnosed right off the top of your head? If you don't, that's fine. But I was just
No,
curious.
I do. I wrote a paper on it. So,
Oh, okay, good.
I mean, I know it national. I mean, I know in the data. I can't tell you for Bloomington, but
Right.
for women in particular, looking just at pregnant and postpartum women, depression rates. So there's obviously a lot of illnesses. We know the most about depression, and it's up to 70% of people.
Wow.
Some studies say as low as 20%, but in our opinion, the better quality studies say up to 70%. Okay. So it's known for women with substance use disorder that they tend to have more co-occurring psychiatric illnesses, more history of trauma. They tend to have more rapid progression of their substance use disorder. So it is very high, and definitely the majority.
That's not that much different from what I do with problem-solving courts. My guess is close to 60 to 70% of our participants and/or women are duly diagnosed, probably close to that 70%. So, okay, I'm sorry I cut you off.
No, I was going to say the rates are definitely different between men and women, and there's more and more research to show that the illnesses are quite different. The addictive illnesses are quite different and respond better to different kinds of treatment. So I don't want to speak about the non-female population because I don't know anything about it.
Okay, thank you. Sorry, I had to get that off my chest before I forgot, because I would have totally forgotten at the end. I know there's no doubt in my mind I would have forgotten. So thank you.
Mm-hmm.
I think next is Terry. So Terry, fire away.
First of all, I'm going to apologize in advance. I have a 65-pound dog that gets a little loud. So hopefully she will cooperate for a few minutes while we get through this. I'm going to do a PowerPoint real quick. So if you just hold on with me here just a second. Okay, can everyone see that okay? All right, good. All right, I'm Terry Cardwell. I'm LCSW, a licensed clinical social worker who's been working in the field of addictions quite a while. And I've been with the program for actually just right around a year now. The program was funded and is currently in the beginning of its third year of a 3-year grant from HRSA to provide services to women who are substance using and pregnant. So what do we need to know about the program? This is very brief. So if you have questions, I'll be happy to answer those at the end. But some things to know about our program. Number one, the goals are to use a harm reduction approach. We generally want to reduce substance use among pregnant individuals. Our ultimate goal is to improve maternal and fetal outcomes and to reduce the incidence of neonatal opiate withdrawal and also neonatal abstinence syndrome in newborns. And also, I think a big piece of what we're trying to move into is to communicate with our communities and educate them about the impact of substance use on maternal care and fetal outcomes. The people who can benefit from our program are those that are pregnant or postpartum individuals with children under 2 years of age, who have a current or recent history of substance use. And I might comment that probably most of what we're seeing right now is a combination of, we see a high rate of marijuana and other cannabis use, including Delta-8. We're also seeing those that have an opiate use disorder as well. And we're also seeing a fair amount of meth. So those are probably the 3 drugs that we see most often with our current population of clients. The program is open to those that live in a 5-county area consisting of Orange, Greene, Lawrence, Monroe, and Owen counties. We currently have a location here in Bloomington, and we've been working with Hope Resource Center in Bedford to get a program up and running there as well. That's been a little bit slower, but we're hopeful that that will come to fruition here before too much longer. So what are some of the services that we offer? We offer a substance use group therapy. This is what we call the Moms Heal Together Clinic. As a licensed clinical social worker, I provide the group therapy. It's confidential group substance support, education, and intervention. We do focus on harm reduction to a great extent, as well as recovery strategies. And I'm sure a topic for another time would also be a focus on trauma-informed care, as many of our women have experienced domestic violence or sexual assault as part of their history. In addition to that, in a 2-hour group session, we meet twice a month on Tuesdays from 10 to noon. And the other portion of that 2-hour period is an array of OB services. Our certified nurse midwife is licensed to provide medication-assisted treatment. And I know that she works a lot with Dr. Arnado around that as well. Dr. Arnado is also our consulting psychiatrist, so we appreciate her involvement. But our certified nurse midwife also does infant heart rate assessments. She does belly measurements. Also, we do blood pressure and weight at each session. And our ladies and pregnant individuals are very well versed in the kind of the way the program starts off. They come in, they do a urine drug screen, they get their weight, their blood pressure, and then meet with our certified nurse midwife. That usually takes up about the first 30 minutes of the group. And then the remainder of the group is a focus on reducing substance use and also talking about the impact of substance use on pregnancy. And that's where it really helps to have a certified nurse midwife there to answer more medical questions, I feel like, that are out of my scope of practice as a licensed clinical social worker. So we really combined having an emphasis on substance use treatment with making sure that mothers and babies are doing well, and that we're supporting pregnancy as well. We also have free perks for mom and baby for regular participation in the program, including free car seats, free pack and plays, what we call a baby box, which is like a baby shower in a box that has a lot of the items that basically you need to start out with a newborn, including diapers, pacifiers, baby clothes, onesies, and probably enough diaper rash cream to cover Monroe County, which moms often use quite frequently. So anyway, for us, it's really all about building a community. All of us have heard the phrase, it takes a village. And it really does. It takes a village that will wrap pregnant women and individuals in support services. One of the things that we talk about in the treatment group is the fact that, women face a lot of stigma in our society to begin with. They come to us oftentimes feeling fairly wounded by their trauma, by their adverse childhood experiences. And so I looked at as one barrier to get across. Pregnant women often experience, people telling them how to raise their children, telling them how they should manage their lives. And, including intrusive behaviors like touching them without permission, which is re-traumatizing for most of our participants. And then when you add substance use into it, it's almost like you're dealing with three strikes. And so part of it is offering a supportive community where pregnant individuals can hopefully get to the point where they're abstaining from substances, as well as being supported to do some emotional healing for themselves and ultimately their family. Two other pieces that kind of fit under this kind of community approach are care coordination. One of the things we make sure is that we check with our patients to make sure that they have referrals to community services. Some of you who are familiar with the community health building on Miller Drive rather, know that our WIC program is there, our nurse family partnership program is there. And we also have the car seat safety check coordinator also at our Miller Drive location. So it's almost a one-stop shop. But we want to make sure that our participants are involved with the community services that they are eligible for. That includes healthy families for those who have been or in a pregnancy for more than the first time, as well as the Pregnancy Promise Program. I don't know how many of you are familiar with that, but that's a program through the state that focuses on providing case management services specifically to pregnant individuals who are currently or have a history of opiate drug use. And so we try to connect them there whenever we can. And then also a program that's called My Healthy Baby that you may have heard about earlier this year. There was a community meeting at the new Regional Academic Health Center with Dr. Box, and who's over the Indiana State Department of Health. And she talked about a new program called My Healthy Baby. So there are some initiatives out there that we can help our participants take advantage of. We also do a lot of collaboration with our OB providers, our mental health practitioners, family services in the community, as well as substance use treatment centers. We have assisted women to get into inpatient treatment centers that particularly have programs specific to pregnant individuals. We work a lot with Dr. Arnado to deal with those that have dual diagnoses that may have not been diagnosed, or maybe someone's not been on medication, that can help them and support their recovery as well from mental health needs. We see a lot of anxiety and depression among our perinatal and postpartum individuals. And so another service that we do offer through the Moms Heal Together is a virtual support group for perinatal and postpartum individuals who experience depression and anxiety. This is open to anyone in the community. It's not specific to individuals that also have a substance use disorder. It's open to anyone who's experiencing any type of mood or anxiety disorder or symptoms. It offers a connection with others who are going through similar difficult period. We do a lot of education on coping with mood disorders, and it's a free resource, and it's led by a nurse from our nurse family partnership and myself, who've both been trained in perinatal. Looks like spell correct took over there. Perinatal and postpartum mood disorders. Some of the comments that we've got back on our first survey of our very first cohort of clients included some of their favorite topics and what they found most important and helpful for them. And as you can see here, it's a combination of, having that support of other individuals going through similar situations, talking out triggers, how to identify them, how to manage them, what are some other coping skills that you can put into place to manage those triggers. The support, the feeling comfortable to be open, to talk about the issues that you're facing. The focus on recovery, bonding with the baby. You see the weight and blood pressure checks here are mentioned as well. One participant mentioned in particular that the favorite thing is that she gets to show her progress. And what she was referring to there is being able to verify for herself as well as anyone else that her urine drug screens are clear. And for her, that's a real incentive to keep coming back. So, I think that we've gotten some good feedback. The program is 16 sessions. It does meet every other week. So it basically spans about an 8-month period. So it covers most of the period of time of pregnancy. Our participants can stay on our program up to 2 years postpartum. So we're hoping that we will see even further progress with this program and see some really good treatment outcomes as a result of being able to provide ongoing services. So this is the last slide. To get in touch with us, to make a referral, you can contact Lori Terrell. Her email and phone number is listed here as well as mine. And I'd be happy to take any questions at the end, or if you have questions later on down the road, feel free to contact either one of us.
Great. Thanks, Terry. And your dog did really well, apparently.
Thank you.
Okay. If there's no questions right at this point, we can go on to our next panelist, which is Sarah Farmer from Catholic Charities. So Sarah, take it away.
Yeah, thanks for having me. So I'm Sarah Farmer, and I'm currently an LSW, close to being an LCSW. So I'm a licensed social worker. And I've been a therapist at Catholic Charities as a student and staff for a little over 3 years. So I landed a spot with this really inspiring crew because I see a lot of the perinatal clients that are referred to Catholic Charities. So we're an outpatient mental health clinic and a little bit downstream of some of the work that you've heard. So we do not treat people who are in active addiction. But we do then receive them for individual therapy once the addiction has been sort of settled and they're a little bit on the other side of it. Then we can dig a little bit more into what's behind the addiction, what the root was. So we take referrals from some of the programs that you've already heard about. So I wanted to share just a little bit of how we do conceptualize addiction a little bit in our setting when we're not actively treating it, but how it kind of like loops into some of the things that you've heard here. I don't have a PowerPoint. That was really helpful, Terry, to see sort of a visual of some of the resources, but I do have a visual of our nervous system, which is kind of the platform that I wanted to share tonight to talk about how we play a part in this kind of web of services. Okay, so this image leans on the work of Stephen Porges and Deb Dana on the polyvagal theory sort of base of literature, which may be familiar to some. But I think this is really particularly relevant when we're talking about perinatal parents. So if we kind of think through things through this visual and this image, This place at the bottom of green is kind of what the goal would be for all of the clients or all of the patients that we see as they're going into parenting, either prenatally or postpartum, that they have joy over a life that they're forming or a life that's been born, that they can be present with their baby, that they can be grounded, open to the cues that they're getting from their baby, so that those early neural pathways are really open for connection. Some of us in addiction conversations can talk about a counterbalance of addiction being connection. So in these early connections between a parent, a birthing parent, and their baby is when that baby's neural pathways are really getting sculpted to continue to be connected later in life. So in this way, some of the work we do is a little bit more preventative in helping really early neural connections between babies and their parent. And then I'll get a little bit to how we work with that parent as well in maybe mending some places that was wounded when they were babies, when they were children. So this is the goal. Of course, anybody in new parenting is going to sort of vacillate to this next phase of activation. So when there's a threat that's introduced and it ignites the fight or flight response in a nervous system. Panic, fear, anxiety, worry, I think is what I see the most in my perinatal clients, just sort of a worry switch that's stuck on all the time. Rage, anger, irritation, frustration. But what I tend to see more of is when that worry switch has been stuck on for so long that the nervous system goes into freeze. So maybe there's some postpartum anxiety in that kind of red zone, and then postpartum depression, where there are feelings of being trapped, feelings of hopelessness, feelings of helplessness, just as some parents get stuck in transitioning into the newborn phase with hormones fluctuating a lot, significant life changes, and it can lead to dissociation. And oftentimes dissociation can be substance use. Substance use is a way to cope in this freeze place or to cope with that fight or flight. And so substance use comes in for numbing. So the goal in the work that we do in our outpatient setting is to bring people down through the deactivation from like maybe that postpartum depression freeze and down into recognizing emotions. The ones in that red zone are the more action ones. So recognizing if they're there, maybe frustration with a partner, maybe irritation that's coming out of sleeplessness, and really getting back in tune with those to hopefully continue on down the ladder to that connected green space. Connection with others in the support system, connection with self, and then of course connection with their new baby. So in order to do this, I'm going to leave this up for this portion. I want to just share a little bit of what we see and what we do in the therapy setting in our clinic. Every client's certainly different, and there's not a formulaic treatment, but I'm going to speak to kind of broadly what we can see generally happen among our perinatal clients. We often do work increasing the self-care routines, and especially the somatic ones. So things where they're caring for their bodies. Because if you're stuck in that blue kind of frozen section, there's a disconnection from your body. And then especially if you're connecting with the needs of a new baby, then that disconnection from your body can be increased. So looking at showering, looking at dry skin and lotion, these little things that are nurturing, that help with the self-care and also calibrate back to the mom instead of just to the baby, and bring that grounded. Increasing emotional expression. So again, moving into that red zone where the emotions are identified. So sometimes traditional talk therapy can do this, just naming emotions, talking through them, and coming back into that red zone from the blue zone. Finding ways to create connection and decrease isolation. So this is really helpful for combating that shame that can be in that blue zone. and bringing people back down into the green where you can be connected in a social way. And then finally, a big thing that we do is treat attachment trauma. So it's very common that when someone shifts into the experience of parenting a baby that they really love, it brings up a lot of things about how they were parented. So many childhood wounds can come up, attachment trauma, places that they were disconnected from a caregiver. So we are all staff therapists are EMDR trained. So we do treat those trauma memories that can really become visible and can go and send people into that freeze space. So I'm going to take this down and then tell you a little bit of the logistics of how treatment can work at Catholic Charities, what our options are. So we kind of have one door, and that's through our office phone number. And they're lovely people who are really gifted at kind of that entry conversation. So people can self-refer. We also receive referrals from some of the programs that have been mentioned here tonight. And at that point, there'll be some sort of discussion with the person on the other end of the phone about which line of treatment will be the most efficient and maybe the best. So typically people will go into individual therapy if that's available. So they'll be paired with a therapist and begin work in individual therapy to really kind of follow their fingerprint of what their needs are for either trauma work or doing some processing around the changes that have happened. But to, again, increase that connection. So have that secure attachment even with the therapist to think through how that can spread. We often will run perinatal groups, and this is specifically for pregnant and postpartum parents. This happens more often when our wait list is full and people can't get into individual therapy, or people are in individual therapy and add the group to their treatment in order to increase their social connection. And this is a 6-week group. And it was designed, the curriculum was designed by a perinatal mental health therapist in town, Katie King, and it gets adjusted a little bit each time with the feedback from the participants, but overall the feedback's really positive and they enjoy the connection that that group supplies, much like the feedback that Terry offered. And then we also at Catholic Charities have other group therapy settings available that are topical. So once somebody's in individual therapy, they could also add that to the treatment to have more connection. And those are topical, including things like life transitions, so adjusting to the transition of parenting. We also have parenting groups that tend to be for children as they get older, but often we've seen parents who have a baby, but also have an older child. And so it's a good way for them to have support for the full spectrum of their family and their ages. And then we also have therapists who are trained in TheraPlay. And TheraPlay is a particular modality that's aimed at sort of gluing back a connection that's difficult. Either it's been disconnected because there was a parent or a primary caregiver that was using substances, or there was a removal from the house. It can happen for children who are in foster care, and it's a really beautiful therapy where it happens with the parent or caregiver and the child. And it's a series of activities and games that are specially designed for repairing whatever was ruptured in that attachment and that connection. There is perinatal and prenatal TheraPlay specifically. I'm not trained in it, but something that we could explore if that were to happen, if we had somebody pregnant who wanted that intervention. But typically it's been with children and parents. And that's a place that we can really see some of that healing happen for mothers or birthing parents who didn't have the connection that they needed as babies or as young children when those neural pathways were sort of being set up, to see some repair and healing that they can then provide that for their children and change that cycle a little bit. So happy again, like others, to take questions now, and also look forward to anything I can answer at the end.
Great. Thank you, Sarah. I was just going to make mention, and I totally forgot that if anybody has any questions here, they could also put some down in the chat, and Lisa can check that out as we get to the end, and we can ask questions to the chat. So thank you, Sarah. Appreciate the information you just provided. Thank you. If we don't have any other questions, then we'll move on to our last panelist, which is Chris Sherwood from Nurse Family Partnership, to give us some information on what they do and what they provide. So Chris, take it away.
Hi, my name is Chris Sherwood, and I'm a nurse with the Nurse Family Partnership. I'm currently the supervisor of our program. Our program is a free and voluntary program, and we are housed under IU Health, but we are actually 100% funded by the state of Indiana by grants. And this is a program that works with first-time, low income, higher risk individuals. And to be eligible for the program, they need to be less than 28 weeks gestation, and they need to be WIC or Medicaid eligible. But not everybody's going to have WIC or Medicaid, because we will, some of our clients are undocumented and are non-US citizens, so they don't qualify for those programs. So we do, that's just a loose kind of financial criteria, and they have to live in Monroe, Lawrence, Orange, Greene, Owen, or Brown County. We currently are servicing about 160 families in these counties, and we work with them from early pregnancy until their baby is 2 years old. And during that time, our goal is to have a healthy baby, healthy pregnancy, and to help them become more financially sufficient by the time they leave our program. And so therefore, that can mean all kinds of things. A lot of what we do is it's home visiting. And the nurse is paired up with a family from early pregnancy, and that nurse stays with them the whole entire time that they are part of the program. And so it's a very, very relational program. We get to know our clients really well. We meet them. Our goal is to meet them in their home. A lot of times that takes a little bit before they're ready for us to be able to allow us in their home, but eventually that's the goal. But we are very we will meet them in the park. We will meet them at our office. We will meet them at Starbucks, at their mom's house, wherever works for them. We try to be extremely flexible with the end goal of it to make it to the home, because that does really show us a lot about the family. And we've been able to do that with pretty much all our families in that relationship. During this time that we're with them, we work as nurses. We are there for, taking care of the medical needs, guiding them with education, et cetera. But a lot of our job is to see what their hearts desire, what their needs are, what their barriers are, and help them find programs or sources in our community to meet those. So that means that we work very closely with Dr. Arnaudo, with Catholic Charities, with Terry, WIC, et cetera. So we do a lot of nursing case management besides that relational piece. A lot of our families have housing insecurities, and we work a lot with New Hope. A lot of our families also have substance misuse, and so that's where we get involved with, who we have on the panel today. And we also try to get them in residential services if that's something that they are willing to do, and that's what they would like to do. We really base it on that. We believe that we want them to follow their own heart's desire, and they are the expert of their own lives. And so we follow that closely. And so that can mean, oftentimes the nurse would really like to see a little bit faster steps, but we got to let them take their steps, and knowing that one small step at a time is where we're going to get to where we want to be. That being said, let's see, I said we really try to get them to those resources. We meet with them at the beginning every week, And then we try to do every other week during different times in this relationship. Around the time of birth, we may meet them every week. We believe in being flexible and dosing our visits to what meets with their needs, which sometimes that can mean they, sometimes whenever you have a baby, you really want help, but other times you don't want anybody in your house. So we really try to be observant of what their needs are and what is going to best support them. During this time that we are a part of their lives, we do have some set things that we follow. A big attachment when the baby's born is really big. We also try to help them find daycare if they want to go back to work, help them find jobs if they want to go back to work. Pretty much it is, like I said, what their hearts desire. We get our referrals from it. You can self-refer. You can be referred from your OB office or your friends. A lot of times our previous clients will refer their friends to us, or relatives or sisters will refer their sisters, etc., to us. This is also a time where we try to build a community among the clients that we have. We do parent nights. We were trying to do it every month for a while. That just got a little bit too much, but we've gone to every 3 months, and it seems like we have better attendance. Now that COVID is a little bit less, we're trying to do them in person, and our goal is to get the families together so that they can meet each other and hopefully form their own communities. We also have a private Facebook group, which we try to encourage our clients to be a part of so they can support each other too. Like I said, we meet them, preferably would be face-to-face, but we are very flexible in that we can meet them virtually, either on like a Zoom like this, by phone, by text, whatever works for them. So I guess the big thing is I want to emphasize it's a partnership. I love that about our name because it really is a partnership. We're not there to tell them what to do. We're there to come alongside them and find out what their goals are and what their needs are and help them meet their goals. And I don't know, we've been in this area for 5 years almost. It'll be 5 years in January. I've been a nurse from the beginning with the group, and I really love that the program. I feel like it's everything that they taught us in nursing school I actually get to do with my clients because I have the time. So that's kind of our program in a nutshell, and I'd be happy to take questions from anybody.
Great. Thanks, Chris. Appreciate it. And it sounds like all four of you in your organizations that you work within or for or with kind of all mesh together at some point in time, or can mesh together from what I heard this evening on all this. Fabulous information. I'll tell you, I honestly had no idea that there was these types of resources available out there. I had no idea, and it was some great information. So thank you all for being willing to do this. I'll turn it over to Lisa. I know there were some questions that the board had as far as presenting tonight. So, and I don't know how you guys want to answer these, but feel free to jump on and answer any questions that Lisa has here.
Thanks, Steve. And yes, thank you all. I'm really glad that this is being recorded, and I'm glad that others will be able to hear this information. It's really valuable. There's a lot of questions. Actually, let's open it up to the audience first, or the other participants here first. Are there questions that you all have for our panelists? Anyone attending that wants to bring in a question?
It looks like Kamala does.
Okay, great. Yeah, go for it.
Do any of your agencies use the Finding Help Bloomington Monroe app or software service? Do you know what I'm talking about?
Yes, we do. As far as it's Finding Help, it's findinghelp.org. It used to be called the Amber.
So if you could all communicate better about what resources there were in real time, would that be helpful?
I mean, I think that would always be helpful to have, the more communication and more connection we have is, I think only helps the patients and the clients that we serve and their families. So yeah, I mean, I'm up for anything. We do have, I will mention this, we do have a link within our electronic record system at IU Health that does connect us to the Finding Help website. So I know that a number of people do utilize that. So
This is Kathy Hewitt. I'm sorry for not being on video, but every time I try, I get dropped. So I did have a question, Dr. Arnato. Is there a place where I could find your paper? I would love to read it.
Yes, I can put, I believe, can put a link to it in the chat. If not, I'll put my email on the chat. So feel free to also email me at my email if I don't get it, if I'm not able to get it on here. So I'm putting my email at IU Health first. Then I'm gonna try to put a link to the paper on here if I can.
Thank you. And for all of you, it has been great listening to you and all the work that you're doing. So thank you so much for doing this.
Any other questions from folks here? The questions that I'm looking at from the board are, a lot of them are about stigma. And I'm trying to summarize some of the questions because they're weaving. One, I think, kind of putting together a couple of the questions is, are you seeing, I personally was hearing a lot of change that's happening in Monroe County over time, and I'm wondering if you all are seeing like a progression or a more progressive way of meeting folks that have perinatal substance use challenges. Like if I know my question's not really clear, but would you say that things are improving for folks who have perinatal substance use challenges? And that's that question. And maybe a question woven into that, how might we do better with regard to folks who are experiencing substance use and pregnant or post-pregnancy with regards to the stigma, the challenge of stigma. So I hope that question makes sense, and you can take it however you'd like, any of you, if you want to respond to that.
I can say a little bit about that. I mean, I think the issue with stigma, it's like two-sided. I think in some areas, like, stigma is improving, but in some ways it's sort of not. I think Terry brought up cannabis and marijuana. I think stigma around that has really decreased, and people feel much more comfortable using cannabis while they're pregnant and telling us about it. And so I think that's important that we know, because there are some risks associated with that, but the biggest risk.
Oh, she froze.
I was wondering if it was me, actually. Okay.
while we're trying to get Dr. Arnato back, I can comment on, that's one of the things that we deal with pretty consistently in the treatment group setting that we have through the Moms Heal Together, is the whole issue of stigma and feeling almost like a second-class citizen at times. And so it permeates it permeates a pregnant individual's life. And particularly, I think if they identify with any gender other than female. So I think there's a lot of work to be done. I think that things will get better over time, but I think it takes again a community effort. I think it takes a collaborative relationship with providers and doing our best, each of us, to educate our communities on what stigma is like and what the impact is. It's not just the adult, it's that stigma gets passed along to the children as well. So there, is intergenerational impact of that stigma, and it's something that we need to be continually aware of and attempting to address.
Thank you. Dr. Arnado, did you want to jump back in, or?
I think Terry said some of the things, but I think the idea really related to stigma has to do with a perception of danger. And something we haven't really talked about actually is maternal mortality. And I'm on the maternal mortality review committee for the state of Indiana. And something that we find is that a lot of our pregnant people that are dying, and that just to clarify, the maternal mortality review committee looks at deaths that occur during the pregnancy and up to 1 year after. And when we look at pregnancy related deaths, those are ones where it's something like due to the pregnancy, the person died. Those are occurring, during the pregnancy or shortly after, and they are often related to medical conditions. But if we look at what are called pregnancy associated deaths, so those are deaths that occurred during the period when the person was pregnant or up to a year after, but the pregnancy may not have caused the death. Those associated deaths are much more common than the related deaths, and they're most often in Indiana caused by substance use disorder or overdoses. And those occur in the late postpartum period, so meaning anytime past those first 3 months. And most of those deaths are occurring in people who have been marginalized in some way, and that is not decreasing. Okay, so and those are very impacted by stigma. Not only stigma, but a lot of the stuff that Sarah was actually speaking to, and this idea of people who are been pushed really away from the services, or if you look at their histories, they have significant trauma as children themselves. So they themselves had DCS, for example, called because they were being victimized in some way, and now their own children. And what we notice is a lot of the calls on them are related to their substance use. Okay, not necessarily related to violence, and the things that happened to them were related to violence, if that makes sense. So neglect and violence was perpetrated on them. They didn't get the help they needed as children. They developed substance use disorders. They don't get connected. They have this difficulty connecting to the caretakers of us because their experience of caretaking is very poor. They become very marginalized, and these individuals are still extremely affected by stigma. So it's just a tale of two kind of worlds, like, yes, well-to-do and middle-class people smoking marijuana are more accepted now as okay, but for the folks that are using some of the heavier substances and who have the trauma often from minoritized and marginalized populations, they are experiencing significant amount of trauma and stigma, sorry, is what I meant to say. And their lives are at risk, and they're continuing to die during the period of child pregnancy and postpartum. So I think I know I've kind of taken it to like a slightly different side, but I just don't want to say like, it is, some things are getting better, but some things are just not getting better, and they're not getting better for like specific group of people that are like just not able to get the services to make them feel included and to make them be able to believe that we have their best interests in mind.
Yeah, thank you. Let's go with that particular segment of the population. Like, if you all had magic wands, what would you yeah, we'll just use that phrase. Like, what do you wish you could do, or what do you think maybe is actually realistic with some added funds, or I'm not sure actually, to be able to decrease that death rate, or yeah, like, what do you think is possible here?
I would like expand what Sarah does and what Chris does. I mean, I think Terry and I, like, we obviously could use more funding, like, obviously, but I would expand Catholic Charities, and I would expand Nurse Family Partnership, and I would make it so Nurse Family Partnership can see not just first time moms. That's their program it's a national program. It's extremely validated. It's an amazing program. I love it so much, and I just want it to be available for like everyone. Like, well, I mean, really everyone, but especially everyone who has substance use disorder. Because it really, just like Chris said, it just takes a lot of time to build these relationships and to get people to trust you. And like, for example, I think I'm really good at this, right? Like I do this a lot. I have good connections with my patients, but I just went to the hospital to try to see someone recently who was about to deliver and had substance use disorder. And I like just put my foot in it basically, and like it did not go the way I hoped for it. And she wasn't able to connect with services. I was very sad about that. But I thought, like, oh, if I'd had a peer come in instead of me, or if I had like a nurse family partner person kind of start it out and start the relationship, rather than like a physician where the power differential just was the way it was, what could we have provided to this person? So I would go with that. I really think I just really think we've got to get to them much sooner, right? Like when like, Catholic Charities working with the children, they do a lot of really family work, and to really try to help people feel cared for. And Kathy's asking about whether there is a pilot, and Chris can speak to this. What I know about other counties, I know some other counties who had NFP earlier, further north from us, have had some funding at times to do multi-paris people with substance use disorder. But Chris, I don't know if there's anything happening like that here in the South Central region.
So currently not in the South Central region, but yes, and they did do a pilot in Indianapolis that went well. And that pilot has also been replicated in several other places in the US. So I totally agree with you, Dr. Arnaudo. I would love to be able to include some parents that have had children before that really need that extra help. That's where we do make a lot of referrals to Healthy Families, who is another great resource that can come alongside the moms that have already had children. It's not a nursing home visiting program, but it is a really good program too. But I would love to see that we get that approved for this area at some point, because it would be very useful.
And I think too, like having nurse, in my opinion, having nurse for working with the people with substance use disorder, including more peers in recovery, working together with the nurses, I think would be really fantastic to provide that two sides of you have the nurse with the medical knowledge and their experience nursing, and as all the experience they have, but then partnering with a person in long-term stable recovery to be able to help bring in our moms who are, and I should say pregnant people who are a little more feeling a little more like they need a person who has sort of had that same lived experience, to really decrease the stigma that they might feel just interacting with anyone in the medical world.
I can just make a real quick comment too. I think that Dr. Arnaudo and Chris have done a really good job of talking about some of the needs for expanding programs like Nurse Family Partnership, and I certainly agree with that. I also think that as a community, there are some things that we can do. Some of the barriers that I see that our clients face are being able to afford adequate childcare, having adequate housing, transportation, even basic cell phone service. If you just get on the west side of Bloomington, it can be pretty iffy as to whether your signal is going to stay with you or not. So I think there are those pieces. There are also, I think there are some additional efforts that we can make as it coming together as providers. We are a voluntary program, but we certainly are. I'm happy to work with probation office, drug court, DCS, and a lot of times in being able to work together as a multi organization to support an individual patient, we can get a lot further than doing it alone. And because I think we sometimes have a tendency to kind of quote stay in our own lane when we actually need to be we need to be crossing other people's lanes and talking about how we can network and make things happen, not only here in Bloomington, but in many other communities across the state.
Terry, thank you. Thank you for bringing those basic needs up. I think that's incredibly important. And even this idea, I don't think they've done this in Indiana, but other states just providing like literally cash to these individuals, because when you have to go back to work, sometimes the work people are going into is like treating some of the substances that we give them that have monetary worth. They can't use it for themselves because they're trying to use it to support, their families. So I think that is another whole, we don't really have maternity leave truly in the United States. So having some way for people to support themselves in the postpartum period. And yes, housing is, getting a 3-bedroom apartment in Bloomington that accepts Section 8, like I've had frantic patients who have the voucher even and just cannot, can't do anything with it. So yes, housing is a big factor, and transportation, huge problem for people, for our people, in terms of being able to get to services. Even we do a ton virtual, to try to meet that need. And as Terry pointed out, the internet's not always our friend, but sometimes people just need to transport themselves to places, and there aren't very many good options here unless you have a vehicle and enough money for gas. So those are excellent points, Terry. And I think just to talk a bit about, our interactions with criminal justice and DCS, I have seen a lot of improvement in how DCS in particular tries to do more family preservation and, work with people to stay together. But I think that's a very underfunded and undertrained group of individuals. Many DCS employees have been my patients in the past when I was doing more general psychiatry. So I know some of the trauma that they face. And, these are very young people often. They're trying to train them, but they're going through a lot of trauma themselves of seeing what's happening to these families. So I think a focus for that group on trauma-informed care, more funding, having ways, I don't know how, because the number of people they're trying to take care of is so large. But really having a focus on violent things that are happening and preventing violence and other kind. And when I say violence, I mean broadly, sexual, verbal, all kinds of violence, rather than focusing so much on substance. And this is actually what DCS is. I think they are trying to do this from my interactions with them, but it's a difficult thing to sort out. So how do we make it more collaborative for the people rather than like punitive or scary? Because we do know a lot of our patients have been separated from children in the past, and that is a major trauma, and that's been studied. And to them, it's almost like having had a child die. And so they are in the significant trauma from that experience. At the same time, of course, we can't have children at risk. And if violence is happening to them, or our individuals are too impaired to parent them, other options need to be sought. Please understand that I believe that, but how do we make this a system that really takes care of people? Because the people that are dying as postpartum people were in many ways not taken out of dangerous situations. So I don't have an answer, But to me, that's a community discussion. You know,
Mhm.
how do we make this system to take care of children more effective for everyone?
And I think part of that is being a trauma-informed community.
Thank you all so much for your responses. Was there anything else anyone wanted to say on that piece? Sarah, yeah.
Yeah, all these things. And I couldn't agree more with all the barriers. That's what we see, even kind of in the place that we are. And yeah, I think my magic wand would be what Dr. Arnaudo said most recently about, yeah, this situation that being help seeking puts you at risk of having your child separated from you. And so this really particular situation where any pregnant person, we're talking about a parent and a child. So the laws that govern the child govern the parent, and it's the parent that we want to seek the help for the sake of the child. So this sort of like paradox that we're in. And what I've seen is a lack of clarity in the person using the substances about what has to be reported and what the consequence is going to be. And so it can kind of get catastrophized, and then people don't seek help because they want to parent their child. And so even just, I think like it was said, like if as a community we can find a way to support help seeking in a way that's not punitive, but also to clarify for parents who might be using substances what the consequence wouldn't be to seek help, like some of these more preventative programs that are in place.
Oof. There's so many questions left to ask, and part of me just wants to be like, okay, we should just pause here. But there's one question that I want to throw in, and I know we don't have much time, but I'm thinking it might be beneficial maybe for somebody watching down the road. This question is, how might someone approach this topic with a family member or friend they're worried about without shaming or stigmatizing them? So I know we don't have much time, but if you have just a couple things you might want to share with whoever might be watching at a later date to help out the community in this way.
Well, for me, seeing things and how things are going in society, and I look back at my generation and what was going on when we were raised, and all of the things that were going on when we were raised, and all of the people that ran away from home because there was abuse going on in their house. And I'm like, we grew up with parents that were emotionally immature when they were raising us. And so all of us, we have trauma from what was going on when we grew up. And so we all heard that you have to end that cycle of trauma and not repeat that. And so we decided we weren't going to repeat what went on in our house, but like what you said before, we just did a different thing because we didn't know what you were supposed to do. They all just said, don't repeat what happened in your family. And so instead of repeating what happened in your family, you did what was crazy in somebody else's family. So I think as a community, we need to have some things where we say, hey, we know we didn't all get the right advice sometimes when we were growing up. And now we're learning that these are some of the best methods that are going on. And maybe you should have this conversation with your family and sit down this way, and we can all have a conversation together, or we can come sit down as a community and learn ways to have good conversations. But I mean, when I look at things now, that's what I'm seeing, that we didn't necessarily learn the best methods in the ways that we were taught to avoid the problems that were going on in our family so that we didn't repeat them again. We repeated a different problem that somebody else had. We just traded the one that we didn't have, that we had in our family, for a different problem. And so we didn't really learn how to do things the right way. And so then people now, they're like, well, these young kids in the generation the Y or whatever, and they're just like, I don't understand why. Well, they're your kids or they're your grandkids. So you didn't do something that you should have done if they're not being respectful the way you think they should be.
Thank you, Kamala. I'm just looking at the clock, and I just want to let a couple of panelists jump in, just with any sentences here or there, with regards to what community members can do. And I really appreciate your comments, Kamala.
One thing I think can help is if a person is willing to, like a family member is willing to come with the affected individual to the appointment. That provides some support for that person with someone who's familiar to them to make that first step. And I think that can be one of the things that it could be a takeaway for people that maybe know someone who needs help.
Thank you.
And I think maybe just saying, I'm noticing some patterns in how you're using substances or how you're trying to cope with these problems that are concerning to me. Like, are you concerned about it? Because often the person is concerned as well. And then if they're saying, yes, I am, you can say, I listened to this panel, and here there are some services, there are people who want to help. Like Terry said, let's go together. Let's check this out. Let's see if it works for you.
That's awesome. Yeah. Yeah, thank you, Dr. Arnotto. Anyone else, any other panelists want to jump in with anything else?
Yeah, I'll go back to kind of what I said before about connection being a counterbalance to addiction. So I would say, like, any way that that family member or friend knows that you're unconditionally caring for them and that you're unconditionally connected to them is going to help.
That's beautiful. Thank you. All right. Well, I am so grateful to all of you. I know we could be here for a long time talking about these issues, but I do appreciate all of your time and energies that you brought to us today. And gosh, Steve, do you want to say anything before we pause for the evening?
Yeah, this has been fabulous. There's been a boatload of information, and I love the fact again that you all are collaborating. It sounds like with each other, and it's wonderful to hear that there are so many other what I would consider donut counties that have access to these services around us, and I just think it's absolutely fabulous. If I didn't know about this, I can't imagine there's a lot of others that don't know about this, and I just wish the word could get out. And I will send an email out to my department tomorrow and ask them to ask them to take a look at this and listen to this, because I can't imagine that some of those that we have on probation don't need these types of services in our community. And I would highly recommend that they sit and listen to some of this, because again, it's been a wealth of information, and you all are doing fabulous work. So thank you very much for what you've done. I have to give, I think Lori's on here, and I have to give Lori credit, because I think Lori, this was Lori's idea to do. And I think it was an absolutely fabulous session. So thank you all very much.
Yes, thank you all. Again, this will be on CATS, and I also have it recorded. So if anyone wants this recording for your organization, please just email me and I'll get you this version. And then it'll be on CATS and however that timeline works. All right. Thank you all very much. I hope you all have a good evening.
Agreed. Thank you.
Thank you.
Thank you.
For now.